Hi, hello, good morning, good afternoon, and good evening. Depends on wherever you are. Welcome or re-welcome to webinar series Road to INAPAIN 2024. I am Ahmad Muttaqin Alim as a moderator here. I'm pain interventionist, ultrasound, and regenerative medicine enthusiast. This session is very special session. We will talk about the musculoskeletal ultrasound in pain management, and we specifically talk about the evidence. Before we start our main session, we will listen open mic from Chairman of INAPAIN, Dr. Yosi, and the main presentation we will present by Professor Ke-Vin Chang. Before Dr. Yosi give an open remark, let me introduce Professor Ke-Vin Chang. Professor Ke-Vin Chang is distinguished physician and academic with a focus on musculoskeletal ultrasound, physical medicine, and rehabilitation. He holds a professorship at National Taiwan University. As a mentor and educator, Dr. Chang is dedicated to training the next generation like me and you. And Professor Chang will be coming in Bali as one of faculty of INAPAIN 2024. So book your seat now and get your chance to know personally Professor Ke-Vin Chang directly at 4 until 6 October 2024. And now let's listen opening mark from Chairman of INAPAIN, Dr. Yosi. Dr. Yosi, the time is yours.
Thank you, Dr. Alim. Good afternoon, everyone. Thank you for coming. Thank you for joining this serial webinar. I hope this webinar can give a very, very, very big and a very, very opportunity for us to learn much more about the pain intervention. And I would like to thank you from Professor Ke-Vin, who will giving a lecture today in this webinar. He's a very, 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 very famous pain physician. Prof. Ke-Vin has a very so many article and journal in the field of pain intervention. So I hope today we can learn so much from him. And I'm also want to thank you from Dr. Alim for as a moderator. I hope for everyone that everyone can join us in Bali on October, and we can share knowledge together, and we can discuss about the pain intervention, and also can meet each other in Bali. Thank you, and I will give you back the time to Dr. Alim, so we can continue the webinar. Thank you.
Yes. Thank you, Dr. Yosi, for the opening remark. Please attention to the audience that to enjoy this session, please have a good connection of internet. And the second, please ask question in the Q&A column. And panelists, Dr. Ke-Vin, Dr. Yosi Prof. Ke-Vin will answer the question, and maybe some panelists will give an opinion in the Q&A session. And this webinar is recorded. So now the main session is the presentation by Professor Chang. Please welcome Professor Chang. Hi, how are you, Professor Chang?
Yeah. Okay.
I'm sure you are always ready in your busy time.
Okay.
And
so can
now,
you see my slide?
Yeah. We see clearly, and we are ready to be enlightened by you in this session before meeting you in Bali, right?
Okay. Yeah.
And please, the place and time is yours.
Okay,
So,
thank
yes,
you.
enjoy it.
First, I would like to thank Dr. Yossi and my dear colleague to inviting me to Bali and also give a talk in this webinar. Today, I just have my wisdom tooth extracted. Therefore, if you find my talk, I have a little slur speech, please forgive me. And also, if I answer your question slowly, also please also forgive me because I just lost a teeth of wisdom. Okay, today my topic is musculoskeletal ultrasound guidance for injection. What is the evidence? So if you want to dig into this topic deeply, you can refer to our article just published in Journal of Rehabilitation Medicine. The title of this article is Comparison of Ultrasound and versus Landmark Guided Injection for Musculoskeletal Pain and Umbrella Review. So I think here we have many experts in this forum. So I'm going to have overview of the following injection technique, including subacromial bursa injection, bicipital groove injection, glenohumeral joint injection, wrist injection, hip joint injection, as well as knee joint injection. But I am not going to talk a lot of detail about ultrasound-guided intervention technique. On the other hand, I'm going to emphasize on the comparison between the landmark guidance with ultrasound guidance. So this is the chronal view of the subacromial bursa. As you can see, subacromial bursa is a structure underneath the acromion. So if you want to use a palpation-guided injection to get into the space, you can consider to palpate the undersurface of the acromion. And then you insert your needle from lateral to medial. And it's possible for your needle to get into the subacromial space. Because nowadays you are going to find it very difficult to find a book elaborate palpation-guided injection. Most of the information can be found. The resources that you can find information regarding palpation-guided injection is usually from the internet, from YouTube. So I have some snapshot of the video and want to use this video to tell you whether this kind of palpation-guided injection is possible to get into the space that you want to inject. For example, in this picture, the doctor demonstrated subacromial bursa injection, just like what I mentioned. If you want to get into the subacromial bursa, it's possible to use palpation-guided to inject from lateral to medial. So, but this is another snapshot from another doctors who try to demonstrate the landmark-guided subacromial injection. But as you can see, the position where the doctor demonstrates is impossible to get into the subacromial space. Instead, the needle where he points to is the glenohumeral space. So if you want to use palpation-guided to get into the subacromial space, if your direction is from posterior to anterior, you must position your needle from medial to lateral. And this is a cadaveric study demonstrating the subacromial bursa was infiltrated by the blue dye. As you can see, subacromial bursa is very big, and it's also connected to the space underneath the deltoid. So that's why another term for subacromial bursa is subdeltoid subacromial bursa. So as you can see, the bursa is very big. So it's covered 2/3 of the rotator cuff. So most of the evidence comparing ultrasound guidance versus palpation guidance for the treatment of subchromic impingement syndrome came from this randomized double-blind prospective study. So in this study, they use a magnetic resonance image to validate whether the injectate went to the correct space. So for example, the left subgraph shows that it was an intradeltoid injection. It means the injectate did not go to the subdeltoid bursa. Instead, most of the injectate leaked to the deltoid muscle. On the other hand, you can find that this was another scenario. You can find that most of the injectate flew to the infraspinatus muscle. So as you can see in this study, you can find ultrasound guidance is not superior to landmark guidance. So when I saw the result of this study, I suddenly recognized that if the physicians were not well trained, the effect of the ultrasound guidance may be worse than palpation guidance. So how about the comparison between ultrasound guidance and the landmark guidance for pain reduction and the functional improvement? The evidence is many from this meta-analysis. So in this meta-analysis, you can find even you use ultrasound guidance, there is no significant difference in pain reduction and the functional improvement. So the second procedure is the bicipital groove injection. So this coronal cadaveric section demonstrates the position of the bicipital groove. As you can see, the bicipital groove is situated between the laser and the greater tuberosities of the humeral head. So if you want to use palpation guidance to get into the space, you have to palpate the bony prominence over the humeral head. So how to perform it? First, you can let a patient to lie down and use your finger to touch the position of the bicep long head tendon. And you can also palpate the greater tuberosity and the laser tuberosity, which is just besides the bicipital groove. So once you validate the position of bicipital groove, you can use a ballpoint pen to have a mark on the skin. And then this is the point where you are going to insert your needle. So then you can insert your needle from distal to cranium, and it's possible for your needle to get into the space. But you can see if you want to look for the evidence of accuracy for bicipital groove injection between ultrasound guidance and the landmark guidance, you have to check the data of this randomized control trial. So in this randomized control trial, they use computed tomography to see the distribution pattern of the contrast media on the CT image. So in this article, they check the outcome of pain reduction and the functional improvement. So in this study, you can find that use ultrasound guidance is superior in landmark guidance regarding pain reduction and the functional improvement. So this is another aspect of pain management of shoulder joint, which is the posterior granule humeral joint injection. So as you can see, the joint space under this coronal cadaveric section, you can find it's between the glenoid and the middle aspect of the humeral head. So if you want to get into the joint space, your needle need to insert from lateral to medial. So this is the horizontal section. Use this view, you can clearly identify the joint space is actually a point to the lateral side. So if you want to get into the joint space, you need to inject from lateral to medial. So how to validate the direction of your needle? So once you insert your needle from posterior to anterior, you can let your needle point to the acromion, and then it's possible for your needle to get into the posterior glenohumeral joint. So let's check the snapshot of the video from YouTube. So the doctor wants to use palpation guidance to get into the posterior glenohumeral joint. First, he used his hand to palpate the space between the humerus and the bony glenoid. And then he tried to use the needle to insert from lateral to medial. As you can see, the direction is correct, but as you can find, the needle is actually very short. So if the patient has a thick deltoid, it's impossible to use such a short needle to get into the joint space. So and then he did the injection in this way. So another aspect is anterior glenohumeral joint injection. So this is the horizontal section, cadaveric section of the shoulder joint. So if you want to get into the anterior glenohumeral joint, you can find that the needle is inserted between the coracoid process medially and the humeral head laterally. And then you insert your needle vertically to get into the space between the bony glenoid and the proximal humerus. So this is another, this is a coronal section. As you can see, just like what I mentioned, it's between the colloid process and the medial aspect of the humerus. So how to do it? By using palpation guidance. First, the doctor palpates the medial edge of the humerus, and then also validate the lateral edge of the coracoid process, and then he used the needle to insert directly to get into the joint. So let's see the result of the comparison between ultrasound guidance and the palpation guidance. The result is from a cadaveric study. So in this study, they use fluoroscopy to validate the distribution pattern of the contrast media. So this is the precise location of the contrast media inside the glenohumeral joint. And then this is the incorrect pattern. As you can see, most of the injectate distributed to the area outside of the joint. So in this study, you can find use ultrasound guidance is much better than landmark guidance regarding the accuracy of the anterior glenohumeral joint injection. So regarding the pain reduction, you can find the result is there is no significant difference regarding pain reduction. So another aspect is the shoulder function. So regarding the shoulder function, it seems that ultrasound guidance is better than landmark guidance. So after the addressment of the shoulder joint, let's move to the wrist injection. So wrist injection, we know the most common pathology that leads to wrist pain is the decrepit tenosynovitis. Decrepit tenosynovitis is the involvement of the first dorsal extensor compartment of the wrist. So if you want to inject to the space, it's not difficult because it's very superficial. So what you have to do is to let a patient to extend the thumb, and then you can palpate the abductor pallucis longus and the extensor pallucis brevis inside the first extensor compartment. So once you identify the ligament, you can do the injection from distal to cranial, and then you can get to the joint. So the evidence of the comparison between ultrasound and the landmark guidance was from this study. So in this study, they validated the results by using the effects of pain reduction and the functional improvement. And the author found the ultrasound guidance is superior to landmark guidance in terms of pain reduction and the functional improvement. So you may ask me, what is the usefulness of ultrasound for decrepit disease, for injection of decrepit disease? Because the tendon inside the first extensor compartment was very superficial. You may think there is no need to use ultrasound guidance. But if you encounter a case like this, actually this case is mine. You can find the figure A. Figure A is a normal image of the tendon inside the first extensor compartment. There is no septum to separate the AB duct pallucis longus and the extensor pallucis brevis. But as you can see at the affected site, there is a septum to separate the two tendons. So actually the patient underwent palpation guidance for 2 times. Unfortunately, I thought most of injecting went to the space containing the AB duct pallucis longus. Therefore, even he received 2 times of palpation guided injection, he still did not feel much improvement in pain. Therefore, we use ultrasound guidance to let most of the injecting to infiltrate the subcompartment containing the extensor pallucis brevis. So after 1 injection, the patient got 100% pain relief. So I think for decrepit disease, the main usefulness of ultrasound is to validate where there is a septum to separate the compartment, to separate the first extensor compartment. So later, let's talk about hip injection. So this is where the hip joint is located. So you may think that we can proceed the palpation guided injection from anterior approach just like this way. But the main concern is in this section, there are the femoral artery, femoral nerve, and the femoral vein at over the needle trajectory. So if you use palpation guidance, using this kind of approach would be very dangerous. So if you want to proceed palpation guided injection to go to the hip joint, you have to use lateral approach. So what is the benefit of lateral approach? Because if you use lateral approach, the needle would have less chance to damage the femoral artery, femoral nerve, and the femoral vein. So how to identify it? If you attend my webinar last week, you would remember that when we have ultrasound examination of the hip joint, there will be 2 bony landmarks that we can easily palpate. One is the anterior superior iliac spine. The other is greater trochanter. So in this video, they draw a line between the anterior superior iliac spine and the greater trochanter, and then divided this line into 3 portions, and then insert a needle at the proximal 1/3 of this line. And then the needle gets into the joint, and then they use fluoroscopy to validate the position of the needle. The needle is at the area of the femoral neck, and it's possible for the injector to get into the anterior lateral aspect of the hip recess and go to the joint. So what is the accuracy between the landmark guidance and the ultrasound guidance? So according to this meta-analysis, you can find ultrasonography had much better accuracy than landmark guidance. So later, let's talk about knee injection. So for knee injection, there are many entry portals. For example, you can get into the knee joint use anterior lateral approach, or you can get into the knee joint through the anterior medial approach, which is through the portal between the medial aspect of patella and the medial aspect of the distal femoral condyle. So let's see the result of accuracy from this systemic review. So in this systemic review, you can find ultrasonography is superior to landmark guidance by around 10%. And this is how the landmark guidance is proceed. If you want to perform the anterior approach, first you have to validate the position of the patella tendon and the medial and the lateral tibia plateau. And then you insert your needle from the window between the lateral femoral condyle and the lateral aspect of the tibia plateau. And also, if you want to perform the medial approach, you can palpate the gap between the middle edge of the patella and the middle proximal middle tibia. And then you can insert your needle like this way. So it's not difficult to use palpation guidance to get into the joint. But the main concern is if you do not use ultrasound guidance, there is a high chance for your needle to damage the distal femoral condyle, and the patient can have pain during the injection. So let's see the result from this systemic review. So in this systemic review, you can find ultrasonography is less painful than landmark guidance. And also, if you compare the result of the fluid aspirated by using ultrasound and the landmark guidance, you can find if you use ultrasound guidance, you can aspirate 70 milliliter more fluid than landmark guidance. So this is a summary of today's talk. As you can see, for shoulder joint, of course, use ultrasound guidance. The accuracy of using ultrasound is much better than landmark guidance. But regarding pain improvement and functional improvement, if you are familiar with the palpation guidance, the symptom improvement may be similar to ultrasound guidance. And regarding the wrist injection, ultrasound guidance seems to be necessary because there are two benefits. The main benefit is just like what I mentioned. You can identify the septum of the forced extensor compartment, and then you can recognize which subcompartment is the right compartment you have to proceed the injection. And for the hip joint injection, the accuracy of ultrasound guidance is much better than landmark guidance, and also for the knee joint. And regarding the adverse event, you can find, according to this meta-analysis, ultrasound guidance may be similar to landmark guidance, but I think use ultrasound guidance can help you to prevent from injury the adjacent neurovascular structure. So according to the statistics results, because it's a great number of patients, so the adverse event may seem to be similar. But if you have one case suffer from this adverse event, it will be your nightmare. So according to this study, I suggest, use ultrasound is very useful. But before you use ultrasound guidance, remember to learn from experienced physician, because if you do not have a correct method of ultrasound guidance, sometimes the result may be worse than landmark guidance. And another thing is, in Taiwan, we have many educational activities. So in December 14 and 15, we are going to have a course featuring the neuromuscular ultrasound scanning and the injection technique. Finally, if you like my talk, remember to join M.Sc. Ultrasound Club on Facebook. In this forum, there are so many experts in this forum, and then you can also share your precious cases in this forum. Thank you very much.
Yes, thank you very much, Prof. Ke-Vin Chang, for the great presentation about the ultrasound versus the landmark. I have some notes here. Yeah, mostly ultrasound is more superior than landmark, but in some case in shoulder bursa ultrasound have a lesser. It's questionable here, but let's discuss with participant and audience. It's time to discuss. There is a question from Dr. Adel Ibrahim. Oh, he asked about the partial supraspinatus tear with pain. How to inject PRP, Professor Ke-Vin?
Okay.
Yeah.
First, before I answer this question, I have to clarify that, the result of my study shows is from the review of the existing evidence. So in this article, the author states using ultrasound guidance was not better than landmark guidance regarding the injection of the subacromial bursa. But as you can see, in this study, the physician who perform ultrasound guidance may not be that experienced. So that's why I emphasized. Usually, if you use ultrasound guidance, I can imagine the accuracy of ultrasound guide should be much better than landmark guide. But if you are not experienced, the result can be reversed. So that's why we have to attend, the workshop to learn the correct injection technique. Okay, let's go to the question. If you want to treat patients with partial thickness tear, partial thickness tear can be divided into several different types. For example, partial thickness tear, intrasubstantial tear, and also articular-sided tear. So before we distribute PRP to the tongue area, I suggest first is if there is lateral effusion inside the bursa and the tongue side, you have to aspirate it first. And then after you aspirate, you just distribute your PRP to the area of defect. And you have to know the result of using PRP to treat partial thickness tear might be equivocal because some doctor said it's going to be better. Some doctor, if you look at some big scale study, they find there was no significant difference. But for me, I think the tip is before you perform this procedure, you have to make sure the tear is partial thickness tear. If it's complete tear, I don't think PRP is going to be useful because if the tendon was retract, even you give the growth factor to this area, they still have difficulty to approximate. And so if once you validate it's a partial thickness tear, just aspirate the fluid and then inject the PRP to the tongue side, and it will be very helpful. Probably you need 1 or 2 or 3 times of injection. Okay.
Yeah, okay, and there are some questions, but before the next question, I will welcome to panelists here. There are, hi, Dr. Andreas Trescott, Dr. Cindy,
Hi.
and Dr. Pranab. Is there any opinion about this? Dr. Andrea, are you there?
Yes, I'm here. Can you hear me?
Yeah, we
Yes.
clearly. Yeah.
Wonderful lecture. I think we have lost the skills involved in doing good palpation and good landmark guided injections. There's a group, the Hemwall Hackett Foundation in the United States, that actually has a course where they make you mark where each of these structures are so that you can learn where the structure is so to be able to inject it. And I think this lecture was very good in combining the live patient, the cadavers, the prosections, the MR, all the imaging, and did an excellent job of combining those. And I think that's what's missing. If somebody says it hurts here and you don't know what here is, then you can't possibly inject it accurately because you don't know what direction the needle needs to go. So learning the landmark, I think, will make all your other skills much better. So instead of relying on ultrasound, which may not be working that day, may have a bad ultrasound where you can't see very clearly. Again, as you said, if you're not an experienced ultrasonographer, actually the injections may be much worse than landmark in somebody who is skilled. And I've had a lot of fun working with some of the people who are really very, very good at landmark injections. I make them place the needle on a cadaver and then look at it under X-ray, and bam, they are right on. But a lot of it has to do with the skill. But I think not everybody has access to ultrasound in the office at the time the patient presents, and really focusing on updating and trying to improve your landmark identifications will make all of your injections better.
Dr. Trescott, do you mean that the landmark can be a basic of the ultrasound approach?
I think that when you put an ultrasound probe on a structure, it's like a little tiny pen light in a great big factory, a big dark room, and you're looking around trying to find with this little tiny pen light where it is you are. It's very easy to get disoriented with ultrasound. But if you've already identified the structure, then you can put the probe on that structure, and now you can see exactly where you need to go. So I think palpation skills make your ultrasound skills better.
Okay, that's I will highlight that for the audience, right? Thank you very much for the opinion, Dr. Trescott. And ada pendapat dari para panelis, Dr. Cindy, Dr. Yosi, before we move to the other question.
Yeah, Dr. Alim, yes, I think I always, when I teach my student or teach in the workshop, I always say about the surface anatomy. So it is very important, the surface anatomy, because it makes easier for us to put where to put the ultrasound first. So sometimes, just like what Andreas told us this, sometimes if we didn't know where to put our probe, that we will get mixed up on something. But
yes, and lost.
The first, if we can get lost. So if the first we can find the surface of anatomy of the place or the region that we are going to scan, it's much more easier for us to find what we going to find. So I think it's very important that we know about that.
Yes, Dr. Rasi. Before we go to other panelists, Para peserta dipersilahkan mengirim pertanyaan melalui chat Q&A. Bebas aja, ini tentang ultrasound dan mungkin sedikit merembet ke yang lain sebelum kita ketemu di Bali. Dr. Cindy, Dr. Pranab, you there? Do you have any opinion about this? Who is first? Dr. Cindy?
Hello, everyone. Hi.
Okay.
Thank you, Dr. Ke-Vin Chang. Very good, interesting presentation. And I also agree with Dr. Andrea and Dr. Yossi. Its combination would be the best probably practice for us. But I see it's interesting about the shoulder ultrasound and landmark injection where the pain relief is inconclusive. Yeah, the result of the pain relief is inconclusive. Probably is it because of the diagnosis, as what Dr. Andrea said, okay, the pain is here, but where we target the injection is not correctly in that area. So sometimes I think the basic is also about where we have to target the injection. Yes, thank you.
Thank you, Dr. Cindy. Dr. Pranab, you have time? Or next question? Dr. Pranab, please. Please open your mic. Yeah.
Can you hear me now?
Yeah, clearly.
Okay, thanks. So no, it was a great talk from Professor Chang, and I thoroughly enjoyed it with all your evidence-based literature. And I echo Dr. Asmar's and Dr. Trescott's view. So we shouldn't forget landmark guided, and not many people have got access. But I think ultrasound is the king of interventional pain medicine when it comes to joints. I completely echo it. I have a question. Now, I've been seeing a lot of patients from ankle. I know you haven't shown any evidence for ankle injections. So we do get a lot of cases post-ankle surgeries. And these are like post-operative patients who've had multiple revisions, and they're going for a triple arthrodesis or joint fusions. My question is, in the context of your evidence-based medicine for shoulder, knee, what are your thoughts about ankle? Is it do you have more role for ultrasound, or can it be just done under landmark or with fluoroscopy? Is the accuracy as important, and is it as comparable compared to the shoulder and hip injections?
Okay.
I know that the second question for this session, right?
Okay.
Okay, Prof. Ke-Vin.
Okay.
Answer.
So because this is umbrella review is the gathering of the evidence from systemic review and the meta-analysis. So actually you point a very good point. I mean, it's a research point. It's because no one has done this review before. So probably it will be my, another study topic. But I think just like wrist joint injection, injection to the ankle joint is not difficult. But the main concern is, for example, if you want to get into the anterior ankle joint, if we use ultrasound guidance, the structure that we may penetrate is the dorsalis pedis. So for example, if I use ultrasound guidance, I use lateral to medial approach to get into the joint space. But using ultrasound guidance is very easy to find the area underneath the capsule. But if you use palpation guidance, I think there are two portals to get into the ankle joint. One is from the anterior ankle joint. The other is actually from the lateral aspect of ankle joint. Recently, we have a study, it's a cadaveric study, to demonstrate the effect of the injection through the portal of the lateral ankle. The portal of lateral ankle is just underneath the anterior talar fibular ligament. And then we find you use this lateral portal, you can get into the joint space and infiltrate the joint space very well. So if I want to use palpation guidance, I would choose the lateral portal to get into the joint because it's safer. I have less concern to damage the deep peroneal nerve and the dorsalis pedis artery.
Thank you.
Okay. There is one more question. It's not about the ultrasound, but I think participants have a interest with regenerative medicine. Yeah, it's question from Dr. Dennis Samuel, neurologist. Do you have any experience in using exosome, not PRP, in partial tear cases? Is it better exosome than PRP?
No, I do not have any experience. Yeah, so probably it will be another in research topic. Yeah.
Yeah, I'll throw to Dr. Andrea Trescott. I hear Dr. Andrea Trescott is one regenerative medicine enthusiast. Dr. Trescott, do you have any opinion?
Yeah, in this day and age, we're very lucky because we've got this wide range of options. Prolotherapy, which I've done for almost 35 years. PRP has the advantage of just being easy to obtain. The bone marrow aspirate, adipose tissue, Wharton's jelly, amniotic fluid, placental tissue, and now this concept of exosomes. So exosomes are packets of signaling material, and they're in the blood, they're in the bone marrow, they're in all over. I mean, it is how the cells communicate with each other. And recently we've been able to separate out exosomes, which have no genetic material, from the stem cell source. And so there's a lot of interest in exosomes right now, and they can actually be used to deliver very specific kinds of signaling material to get your own stem cells to come in, or to turn cells on, or to lots of different issues. However, there's very, very little evidence yet about their use. They're very exciting. I have seen we use exosomes in our practice, and I've seen some very, very, very interesting improvements in pain problems, but I don't think we yet know where they're best going to be used and how they're best going to be used. So I think I tend to stay with Prolo and PRP right now because we have much more evidence for those regenerative approaches. And so I'm not quite sure I answered the question. Is that close enough?
Yes, Dr. Trescott. And I think interest of the regenerative medicine is growing. And Dr. Yossi, we hope you make a session, special session for regenerative medicine. And this last question, Professor Ke-Vin, you mentioned that the improvement of pain ultrasound is superior than landmark. Is it because the accuracy or the medicine, or I mean the modality?
Oh, okay. I think it's a very good question. As you can see, if you compare the result of major joint, the use of ultrasound may not be that superior. I mean, much better than landmark guidance, because if you are good at landmark guidance, even you use palpation, you can get into the big joint precisely and correctly. But for some small joints, for example, at the wrist joint, ultrasound is not only for guidance, it's also for diagnosis. So I think the benefit of using ultrasound is you are going to know what happened to this patient and validate the pathology before you do the injection. I always say diagnosis before you proceed the injection. I remember many years ago, I encountered a case refer for me for injection of the intercostal nerve. And actually, I look at the history of the patient. The patient is a case of colon cancer. And she was treated with some intercostal neuralgia in a clinic for around half a year. But due to the aggravating pain, he was referred to my clinic. So before we proceed another intercostal nerve injection, actually what I did is I tried to scan what happened to her painful area. And I find there was a mass emerging from the two rib space. So actually the patients had metastatic cancer over the liver, and the cancer cell infiltrate in the costal nerve and causing pain. So that's why, I think, every time when you proceed the injection, it's better to use ultrasound to have a scalp scanning to see what happened to the patient. If the patient's pathology corresponds to your impression before you do the injection. I think that's another major benefit of ultrasound. Of course, for some, for example, some small structure, for example, the nerve, ultrasound can provide much advantage than palpation guide, because if you want to use palpation guide to block the nerve, it's very difficult, because you can rely on electric stimulation, but if you use ultrasound guidance, you can clearly see the nerve and to infiltrate the area beside the nerve. So I think so. Actually, if you have ultrasound, I of course recommend you to use ultrasound, but do not forget the physical examination, the anatomy of the structure you inject is the basis of using ultrasound. If you do not know the anatomy of this area, even you use ultrasound, you see nothing, because you don't know what is in the image. Okay, thank you.
Thank you.
I have to.
Prof.
Yeah.
Oh, okay.
You can't treat what you can't diagnose. And the poor term bursitis has been applied to everything for things that have actual very precise diagnosis. So ultrasound from a diagnostic point of view is very, very important. However, the question was about using it for accuracy of injections. Very nice, very, very nice lecture. Thank you for including me on the panel.
Yeah. Thank you very much, Prof. Ke-Vin, Dr. Andreas, Dr. Cindy, Dr. Pranab, and Dr. Yossi. Do you have any close remark, Dr. Yossi, before we close this session? No? Okay, thank you. And one question, but we penned this to Bali from Dr. Yaksan Arsad. We thought ultrasound, how do we differentiate between tendon tears leading to surrounding structure effusion or inflammation versus tendinosis? It leads to type of injection we want to use. Dr. Yaksan Arsad, we will answer this question in Bali, I think. And please enjoy us in Bali in the symposium. It's still open, and the link will be provided by the committee. Thank you, Prof. Ke-Vin. Thank you, Dr. Andreas Trescott, Dr. Cindy, Dr. Pranab, and Dr. Yossi, and all of you are participant here. And the conclusion, I can't conclude anything. Everything is conclusion here, but ultrasound is very useful for us, of course, as an interventionist. And let's register to INAPAIN 2024. This is the link and the QR code. You can click and register. And see you in Bali in November. Oh, I forgot. Next week, we will meet Dr. Andreas Tresot again. She will talk about care analgesia in pain management. Of course, we will meet her in Bali, of course. Is that true, Dr. Trescott?
Nah.
Yeah, okay. And please kontak Mbak Yuli. Saya kira para peserta sudah sangat kenal Mbak Yuli dari ya Pain Institute of Indonesia. Silahkan kontak langsung atau klik di QR code yang tadi sudah diberikan. Sekian dari saya. Terima kasih kepada panitia. Thank you. See you in Bali. Saya Ahmad Muttaqin Alim. Terima kasih atas kehadirannya. See you and dadah.
Thank you. Thank you, Andrea. Thank
Thank you
you.
all.
Thank you, Ke-Vin. Thank you, Dr.